professor from the France, United States, and Asian country. The official opening is tomorrow at Sheraton Hotel. So today I just only give a simple opening. Today our conference this morning is majorly pre-live training course, and this afternoon a live demonstration. And tomorrow we have another meeting at the Sheraton Hotel for deeper tumor ablation and beyond tumor ablation. So welcome everybody here this morning, and please give your comment and interaction with our lecture. So first I will invite Professor Shi. She's the chief of this chairman, also the chairman of National Taiwan University. Please, Professor Shi, give us some brief opening.
Thank you, President Lin. Distinguished guests, dear colleagues, I feel very happy to be here this morning. I would like to appreciate my big congratulations to all of you to have such a great organization and informative conferences. As we know, the tumor ablation brings another choice as an alternative treatment way to have a curative treatment of the tumor. All the doctors from different fields such as internal medicine, surgery, diagnostic and interventional radiology, and etc. all together will perform the tumor ablation with different methods to treat the cancer or tumor patient. I think this is a very important step in the past decades, and all the patients suffering from tumor have different treatment way beyond surgery. And this is the first time for the ACTA symposium with attending doctors from Taiwan, China, Korea, Japan, Europe, France, and United States. Yeah. To be a department chair in NTH, I'm very happy to have all of you here to attend this conference. I'm sure this ACTA symposium will bring all of the doctors together and have more discussion and more informative and exchange of the experience. So let me express my congratulations again, and thank you all of you.
Good morning, friends, and we will start the session. And this session is an overview of operation. And so, but unfortunately, the one speaker does not come to this session. So, 4 speakers. And so, time is maybe enough to discuss. So, and first to speak, and I will chair, and end of every speak, and a couple of questions is available. And finally, we discuss about over all the speak. So we will start this session. The first speaker is what are RFA and microwave ablation. And Professor Chiao, please. And let me brief introduction to the Professor Chiao, to the doctor coming from abroad. And he's a very famous radiologist, and he worked at Taipei Veteran General Hospital. And Taipei Veteran General Hospital is one of the largest hospital and sophisticated hospital in Taiwan. and more than 3,000 bed, child.
Yes.
Yeah, very huge hospital and very
About 6,200 beds. A huge disaster.
And I will a very practical hospital. So, and I will expect and I will enjoy his talk. So, why don't you start your lecture, please?
Yes, thanks Professor Tanaka and Professor Yang's introduction. Actually, because one of the speakers in this session cannot join us, so I was asked to extend my speech. So I hope you will not feel boring. And first of all, on behalf of Tata Society, Professor Lin and me and all our colleagues welcome everybody to Taipei for the ACTA 2014. And we hope you enjoy Taipei and hope you enjoy this conference. Today my speech outline is what is IFA, what is microwave, and the IFA comparison with the microwave. And I will also briefly introduce operation surgery in Taiwan, and then the role of the IFA in HCC treatment, and the factors related to the effect of the IFA, and finally briefly introduce how to enhance the effect of the local operation. So what is IFA? We know the history. The Hippocrates have said, those diseases that medicine cannot cure, the knife cures. Those which is the knife cannot cure, fire cures. So we know from ancient time, they already know can use the thermal, the temperature, the high temperature to cure disease. And in 1881, Diasono found when the alternative currents through the living tissue, the temperature will be elevated. And in 1928, used this mechanism to design the knife, electrocauterization knife. And it found between the generator and the ground plate. The ions in the tissue move back and forth between the electrode and the ground plate, and then produce the friction heat. So in the operation room, I think many surgeons already use this cauterization for the cutting tissue or for the hemostasis. And in other fields, we already using this for such as the trigeminal neuralgia treatment, or also in cardiac arrhythmia treatment. And about 15 to 20 years ago, we used this mechanism to treat the tumor. So this is a simple figure we can see. We use only one probe or one electrode, direct inserted into the tumor. And then when the currents through the tissue, the friction and the heat production, then the heat conduction to the whole area of the tumor area. If the temperature is above the 50 degrees Celsius for 3 to 60 minutes, then the tumor area will be killed. We say this is a tumor necrosis. Sometimes we already know if there is a big vessel near the tumor area, they maybe have the hissing effect. Or sometimes if too much charring tissue or vaporization gas here, then the conduction effect may be not so good. So the treatment area may not be so larger. So that is why we say this is complete operation, this is ideal condition. And in the other hand, this is another ideal operation. We call it incomplete operation. So this is the between the temperature and the response of the tissue. We can see this is normal body temperature. And if the temperatures increase gradually, such as in 50 degrees Celsius, then the cells will be killed in minutes. Then to the 60 degrees, it's within in the seconds. So the ideal temperature range for the IFA, we say, we hope the ideal temperature is between 50 degrees to 100 degrees. And sometimes we also hope maybe a little higher, to 60 degrees to the 100 degrees. And how about the microwave? We already know in our daily appliance in our home, microwaves for tissue ablation similar to the microwave oven. The microwave energy causing water molecules to spin, creating friction resulting in heat generation. But there is a little difference. The microwave oven irradiates electric field inward, but the microwave ablation is the antenna radiates the electric field outward. So this is the first generation, was developed in Japan. The gauge is 13 gauge antenna. It's a little bigger than the second generation. The second generation from the American and also from the Europe. And nowadays we can use the antenna is between the 14 to 17 gauge. So this is the frequencies spectrum difference between the IFA system and the microwave system. The IFA system for the operation, usually we're using around 450 to 480 kilohertz. And for the microwave spectrum frequency, we usually using the 900 to 2400 megahertz. This is the newer design, so it can produce the heat more quickly. So we can see this is IFA frequency, and this is microwave frequency. And the heat generation in tissue is a little different between the IFA and the microwave. In the IFA, the tissue is ionic agitation, so amount of the current delivered is based on the impedance of the tissue. And the ions focus at the electrode and the current density. And in the microwave, we cause in the tissue the water to rotation. And after the rotation, the friction caused by movement of the water molecules against each other. And then the mechanism of friction is different, but the source of the heat is friction in both. So it's a little, the design is a little difference between the IFA and the microwave. We can see the IFA, the current flows along a circular pathway electrode, and the electrode passes the current. So the electrode can passes the current and here. And the current flow along a circular pathway. And in the microwave, we have no current flow in the patient, and the antenna radiate inward to the outward inside the tumor area. So we have a small conclusion between the microwave and the IFA. The microwave, the antenna broadcasting the waves is around 900 to 2450 megahertz. And in IFA, the current is below the 500 kilohertz. And the energy deposition limited around the antenna in the microwave. And in the IFA, the energy disperses but refocus to the ground plane. And in microwave, the power reflection, so the needle or the antenna will be hot and the cable. So sometimes we need the heat insulation, but this is already overcome in the newer design. And in the IFA, the applicator and the cable, not hot, only electrical insulation. And in the microwave, the active heating not limited by the charring, so the temperature usually is higher than the IFA. And in the IFA, the conduction heating, so it's limited by charring tissue, and usually the temperature is below 100 or 110 degrees Celsius. And in the microwave, the supported multi-applications simultaneously. And also in the IFA, we can use in multiple applications now. So in the clinical reference, some benefit for microwave ablation in the liver, such as we don't need the ground paste, so the no ground plate burn and facilitate the setup, especially in the surgical room. And in the microwave, we can produce larger and faster ablation and less hissing effect. But we must be careful about the possible burns, especially the shaft and the cable, and maybe have a high risk for adjacent vascular damage. So secondly, I will briefly introduce the ablation therapy in Taiwan. In Taiwan now, most of the cases we perform the liver tumor, such as HCC, metastasis, or a few cases of cholangiocarcinoma. But we already started to using the local ablation in such as the kidney tumor, the adrenal tumor, including the benign adenoma or the malignant tumor, such as metastasis or cortical carcinoma. And also we using for the kids in the bone field for the osteoid osteoma. And in some cases, for the soft tissue tumors, such as variant deep kind of the sarcoma, and also in the lung tumor. And we also begin to use the IFA in the thyroid tumor, and also using the cryotherapy in the prostate tumor. And maybe in the near future, we will use in the breast tumors. This is our hospital, my hospital. From 2002 to 2013, we have performed more than 3,000 IFA procedures in more than 200 patients. Most of the patients is liver tumor, such as HCC and the metastasis, and also the kidney, the adrenal tumor, the lung tumor, the bone tumor, and some soft tissue tumors. So in Taiwan, maybe later in the international forum, we will describe this again. The IVA procedure performed in hepatologists about 50 to 55%, and in the interventional radiologists is between 35 to 40%, and others is performed in the surgeon. And nowadays in Taiwan, we have several different kinds of IFA and microwave devices. Such as we have the Rita, the Q-tip, and in the recent 3 years, we also have the IFA from the Korean company, such as the Big Tip or the Viva. And the Lavin is we already have used this several years ago. And such from Europe, we using the Olympus, the Ceylon. This is a bipolar, not the original monopolar. And also the microwave we use in the Evident or the Mediwave antenna. So this is the first 3 equipment we can use in Taiwan about 15 years ago, since 15 years ago. And this is the IVA system from the Korean company. And this is microwave system nowadays we using. Okay, so then I will briefly introduce the role of the IFA in the HCC treatment. I think most of our audience already know. In the HCC treatment, the early stage, we strongly recommend 2 methods. One is the surgical treatment, including the surgical resection or the liver transplantation. And the other is a local operation. And usually the effect is good. The potentially curative treatment, we call this third method. And the 5-year survival rate is usually larger than the 50 to 70%. This is our article about HCC in the past 3 years. And I will just briefly introduce such as the survival rate between the IFA and the surgical resection in patients with smaller HCC. In this study is a cohort study. We including the 190 patients receive IFA alone, and the other is 229 patients receive surgical resection. This is inclusion criteria according to such as the Milan criteria in liver transplantation. And we can find The patients in the IFA group had a lower overall survival rate and a higher recurrence rate than those in the surgical resection. So this is between the surgical resection and the IFA. But we can see the demographic data is very different between the HCC patient and the surgical resection patient. So we're using the propensity score matching, and we find the IFA was not inferior to surgical resection in overall survival, but the surgical resection had a lower incidence of developing recurrence than IFA alone. But how about the very early stage HCC patient? Lies in the BCLC stage 0 is one single tumor, and the tumor size is smaller than 2 centimeters in size. So after the propensity score, this is before the propensity score method, we found there was no statistical significance between the IFA and the surgical resection in overall survival and the recurrence. Even after the propensity score, there is no significant difference. So we can make a small conclusion according to this article. Though the recurrence rate is higher, the overall survival rate of IFA is comparable to surgical resection in patients with small HCC. Moreover, IFA is as effective as surgical resection in BCLC stage 0 for a single tumor smaller than 2 centimeters in size. So this is in American in 2010. This is a guideline for the HCC treatment. We can see for the very early stage 0 patient, the first choice is still the surgical resection, and the IFA is for the early stage HCC patient. But in Europe, is some doctors already proposed. Maybe in a very early stage, HCC patient, we can use the IFA as the first treatment choice, and in addition to the early stage. So in according to this article and other articles, so maybe in the future, operation can replace some patients for a surgical resection patient in a very early stage HCC. And how about the factors related to the effect of IFA? We know the HCC tumor genesis, including the tumor factor, liver function factor, the viral factor, and the hepatic fibrosis factor. Such as the viral factors, in our research, the viral etiology between the HBV and the HCV does not impact on the outcome of the small HCC patient who undergo IFA. And how about the AP response? We found that the AP response predicts outcome of the patient with initial serum AP level